Welcome to Stories of Amazing Grace. The views and opinions expressed on Stories of Amazing Grace are those of the guests appearing on the program and do not necessarily reflect the views and opinions of the Madison Church of Christ or the producer of this program. Enjoy.
Well, good evening. I'm Larry Souter, and welcome to Stories of Amazing Grace. We're coming to you from Bixler Chapel at the Madison Church of Christ in Madison, Tennessee. Thank you for joining us on YouTube and by way of radio, being a part of our live audience, and I encourage you to be a part of our live audience also on the first Wednesday night of the month at the Madison Church of Christ, Madison, Tennessee. This is Bixler Chapel at 6:30. We'll be glad to have you here. Well, our theme scripture comes from Romans 8:38 through 39. I'm sure that nothing can separate us from God's love. Not life or death, not angels or spirits, not the present nor the future, not powers above or powers below. Nothing in all creation can separate us from God's love for us in Christ Jesus our Lord. Our guest tonight has attended here as a child, right?
Yes, sir.
But you're wayward now. You're going somewhere else. Yeah, okay, but glad to have you back tonight. His name is Stan Overstreet, a son of Jim Overstreet. He's a crisis supervisor with the Mental Health Cooperative located in Metro Center here in Nashville. They take phone calls 24/7, 365 days a year from those who are experiencing a mental health crisis. Stan's appearance is somewhat timely tonight in light of the recent mass shootings in California, in Texas, and Ohio. And also, since next month is National Suicide Prevention Awareness Month. Here's some facts that you may not be aware of. 1 in 4 people experience a mental health illness in a given year. Adults living with serious mental illness die on the average of 25 years earlier than other Americans, and these illnesses are treatable. Terrible mass shootings this past weekend, but suicide is much, much more common than homicide, which is surprising to me. Before we meet Stan Overstreet, watch this video on the mental health crisis in America.
When it comes to mental health in the U.S., there's a lot of talk and little action. Many fault mental illness for things like mass shootings, even though most mentally ill are not violent. But few point out that every year, close to 44 million adults will experience a mental illness, and less than half will receive care. And 40% of those with severe mental illnesses like schizophrenia or bipolar disorder won't get the help they need. Here are 5 ways the mental health care system is in crisis. Compared to 50 years ago, there are far fewer people in mental institutions today, which sounds like a good thing. When you think about mental institutions, you think about Girl Interrupted or One Flew Over the Cuckoo's Nest. Scary places with mean staff and catatonic patients, unsanitary, inhumane, lobotomies. Which was true according to a bunch of exposés on mental hospitals back in the day. Public outrage combined with the first effective antipsychotic drug put politicians on a path of reform. So in 1963, JFK signed the Community Mental Health Act, which accelerated what's known as deinstitutionalization. That means institutions were closed and patients moved back into their communities. There, they were supposed to get care in newly funded community mental health centers. The idea was to create a less restrictive setting and protect patients' civil rights. Good plan, but after all these years, these community mental health centers still have never been fully funded, and the program has fallen by the wayside, and a lot of people who were released never got the services they needed. Then in 1988, President Reagan slashed federal mental health spending by 25%. So where do people end up? For a lot of them, jail. In 2012, there were 10 times as many mentally ill people in prisons and jails than in state hospitals, and close to 400,000 adults with untreated mental illness are in jails. In effect, prisons are the new mental institutions, which according to the National Alliance on Mental Illness wouldn't be the case if there were better services. There also aren't enough people to help. There are fewer psychiatric professionals to go around compared to other healthcare professionals. Close to 90 million Americans live in areas with a shortage of mental health care providers, which can mean long waits for treatment or long distances to travel. Or there just are no options, period. Because if you really needed help and inpatient care, the US has only 28% of the beds needed. And even if you find the perfect doctor, your insurance might not cover your treatment plan. Insurance companies used to be able to charge higher copays for psychiatric care than for other medical treatments and limit the number of visits, all the way up until 2008, when the Mental Health Parity and Addiction Act forced insurers to cover mental illness equally. But experts say insurers are still finding loopholes. And what about all those people who didn't get access before the law changed? You might go see your regular doctor once a year, but if you need to see a psychiatrist once a week, those copays add up, especially when you're on a tight budget. New rules or not, cost is a real barrier, and non-traditional treatments like acupuncture often aren't covered. Of course, in order for any treatment to work, patients have to seek it out, and the stigma against mental illness can hold people back. We often treat mental illness as dangerous or as a character flaw, and the fear of being ostracized or institutionalized is real. That's why admitting you need help is the first challenge, and the second is actually getting it. So isn't it time we have a conversation about mental health that actually leads somewhere, instead of just throwing up our hands?
And please welcome Stan Overstreet. Come on up. Welcome, sir.
How are you?
All right.
Good to see you. Thank you, sir. Thank you.
Well, what'd you think of that video? Was it factual or not?
I think it's pretty factual.
Okay.
I really do.
So we have a serious crisis here in America.
Yes, we do. We have a serious crisis here in the city.
Yeah. And you work with a mental health cooperative.
I work with a company called Mental Health Cooperative. It's a private agency here in Nashville. It is kind of like about 26 years ago, 3 smaller agencies came together to work as one to give a more holistic approach, more connected approach.
Is it a government program or a private program or both? Or?
It's a little bit of both. It's funded in largely by the State Department of Mental Health,
yeah,
as well as various BHOs, insurance companies.
And your job is crisis supervisor?
I'm one of the crisis supervisors.
Now, what does that mean?
I directly supervise about 6 or 8 individuals on an ongoing basis from a clinical and administrative standpoint. I also supervise the whole team per se on the days that I'm there. I try to keep things moving as well as possible.
Right.
I do a lot of clinical consults throughout the day with like our triage employees who take the phone calls to make sure we're doing the right thing. And then I also do clinical consults with the actual crisis counselors that are going out into the field.
Now, you gave me a tour of the place in July. My initial thinking of this facility was a bank of 4 telephones in a dark room with people answering emergency phone calls, but it's not that. You definitely have a bank of phones, yes, and what you call the fishbowl?
Well, we've got all kinds of colorful names for it. I often refer to it as a fishbowl because we're in the center of a treatment facility.
And how many people are in there?
Oh, at any given time, there's probably 10 to 15.
Then you have that area, and when I first came in the door, help me here with this tour. But
sure,
you took me the room you took me to the first room was the intake room. Is that right?
One of the intake offices.
Where
yes,
you find out kind of what.
That's where somebody walks into our facility. We take them into an intake room to give them privacy, to kind of give us a heads up on what's going on. We have several safety measures and procedures that we go through when we're checking an individual into the facility, and that's kind of where that process starts.
You take all that information there. In the fishbowl area where you have all the telephones, how many calls do you receive a given day or month?
Oh, gosh.
A week or whatever?
I know last month we did 662, I believe it was, face-to-face interventions or crisis assessments. Typically, on average, that'll run 7 to 10% as far as how many phone calls we got. So last month, we probably got at least probably 7,000 phone calls,
Really?
I guess, for the month of June.
And what is the primary reason for the call?
That can be anything. Lots of people will call just seeking information about resources. I would say predominantly the large portion of our calls come from either individuals out in the communities or workers at hospitals or various resources around town that need us to come out and do a face-to-face crisis assessment on someone.
Going on with this tour, another room that I saw was more colorful, had children's furniture in a sense.
Yes.
But you said try and lift one of the chairs, and although they were a colorful chair, maybe covered with a plastic or something,
yeah.
they were inside, they were concrete,
yes.
designed not to be picked up and thrown at you. Is that correct?
That is correct.
Wow.
And that, matter of fact, all of the furniture and things that we use
throughout the facility?
Throughout the whole facility
okay.
are like that. And that's just a safe, no, that's throughout the whole facility. That's part of the safety procedures for if they bring somebody in that's like out of control or something like that, they don't start picking up chairs and tables and throwing them.
Have you had some experiences along that line where you have been assaulted?
I have never been assaulted. I've been threatened several times.
Yeah.
Yeah.
And behind the glass in the fishbowl area was another area where you had some cots, not cots, but beds of some type where,
yes, sir.
Where people were in there.
Yes, sir. We have a large room. We refer to it as our Unit 1. Once we bring somebody in and we do the check-in procedure with them and then they see a crisis counselor, that person starts coming up with a plan on what to do for this person to help them, to get what they need. If we decide to keep them in one of our treatment facilities, we usually move them to Unit 1. It's kind of like I look at it as kind of like a 24-hour bed type unit where we can get them checked in, get them to see one of our mental health providers, get them evaluated, get them hooked up with discharge planners, peer specialists, stuff like that to start that treatment process.
Well, part of the facility, I think, it was across a driveway.
Yes, sir.
Was looked like a mini hospital emergency room type,
yes, sir.
Facility. Is that connected with what you're doing?
Yes, sir. That is one of our treatment options that the
Okay.
crisis team uses. We refer to it as the crisis stabilization unit. There's a few spread across the state. Nashville's very fortunate enough to have that here in our city. That is like I refer to that like a voluntary.
And how long can they stay there if someone has a...
Typically somebody comes on that unit, you're probably looking 72 hours.
Okay.
Typically. They're there on a voluntary basis. They're seen by a mental health provider, peer specialists, they do groups. It's kind of like being in a psychiatric hospital, but I hope it's a little more
Different from what we saw on here, yeah. On the video. Yeah.
Light years.
Yes,
Yes,
yes.
absolutely.
And another little room was an intake area where police could drop off people they have picked up maybe on the street or at a
Yes,
house.
sir. We have working relationships with the Metro Police Department as well as the FBI and the Secret Service. If they flag an individual in the community that they have concerns about, that they know that has a mental health history involved with their situation, oftentimes if they encounter them out in the community and there's a problem, or they feel like that person needs an emergency intervention, they will either call us to come to them or they do have the option to bringing them into our facility, and we have a special entranceway where those individuals are brought into our facility.
Secure area.
Oh, it's very secure, yes, sir.
Well, why would you get into this profession to begin with?
Oh, my gosh.
This is a stressful, it seemed like a stressful and dealing with strange folk.
Well, it's challenging. I guess the way I got into this is I guess I could thank my psychology teacher when I was in high school. I was very interested in the subject, so when I decided to go to college, I wanted to major in psychology. I did that. I got out of school for a while. I worked for a while. decided I wanted to go back to graduate school and did that. And that's where I kind of ran into some of the people that I work with now. And they were telling me about the agency and what they did and what they offered. Obviously, I did not have any mental health, official mental health experience at that point in time in my life. And connected with them to get in the door, so to speak, to get my feet wet. I worked doing various things for them for about 1.5 to 2 years. And one day I just happened to pass the director of crisis team in the hallway, and he was like, "Didn't you finish your master's degree?" And I said, "Yes, sir, I did." He said, "Well, have you ever thought about coming down and working on the crisis team?" And I hadn't ever really thought about it. I had worked in association with some of the employees on the team at that given time in the past. Went home, talked to my wife about it, thought about it a little bit, prayed about it a little bit, and decided I'd give it a shot. And I've been there for, I guess, probably about 22 years now.
You see God working behind the scenes in any of that and placing you in that position?
Oh, yeah, definitely. You know, like you say, it's a challenging mission. It's different every day when I go to work. My mother, before she passed away, told me, you know, she asked me one day, she said, "Have you ever thought about sitting down and writing a book about all this?" And I said, not really, because I've probably forgotten more than I remember. But being the challenge that it is, you know, I've questioned sometimes, you know, okay, why have I stayed in this long? Typically, most people don't stay in it as long as I have.
They burn out or what?
Yeah, burnout's probably about a 2-year span, I've been told. Now, I don't know where that came from, but that's, statistically speaking, that's what I've heard. And I was talking to my wife about it one night, and, you know, I was like, you know, I'm not sure, maybe I don't need to do this anymore. And she said, "I think you do." And I said, "Why do you think that?" She said, "Because of all the people I know, I think you're there for a reason. And I think you're there because God put you there." And I was like, okay, I can go with that. But, you know, it's, to you, you say it's possibly stressful, challenging, and it is. But I look at it from a different perspective when I'm there. I think part of the thing that helps me is I've been there for so long. Things that might seem very traumatic to you or someone else are not quite as traumatic to me. It's not that I don't feel empathy or sympathy for someone. It's just that I've been exposed to it so much. I look at it from a different perspective, so to speak. So I think that helps me do a good job, or at least I hope it does.
On your website it says, "No wrong door philosophy." What does that mean?
No wrong door philosophy? That's a great question.
Have you heard that before?
No, I haven't. Maybe I need to look at my website.
Well, okay.
I would say, you know, the agency, I think the agency has a great philosophy in the sense that it's an open agency.
Okay.
That's probably where that comes from. Our CEO.
Let me check that is correct.
Okay. I think the CEO of our agency has always had an open door policy, and that's the fact that you should always have access to anyone, to be able to talk to one any chance you get.
The website elaborated on that by saying, basically, you don't have to be drug-free to continue treatment here. We don't have to be sober, completely clean to get treatment. I wonder in our churches, perhaps we expect non-believers to be completely clean of whatever sin they have before we accept them. I'm not saying necessarily we do that here, but in some churches in general, I think maybe that's the case.
I think that's a mindset that probably has changed a lot over the years.
Yeah.
Sure.
I was going to ask how you help, and on your website says there are 3 areas here: behavior health services, physical health care, and pharmacy resources. I guess that means drugs.
That is correct.
Yeah.
Yes. And actually, we're also opening obviously everybody knows about the opioid crisis that's going on.
Tell me how big that is here in Tennessee.
It's huge. It's huge everywhere. We see it every day. One of the interesting statistics, and I don't know a specific number per se, I don't know if anybody's ever calculated it because it's so high. We drug test everybody that comes into our facility. Part of that is just to know how to treat people based on their symptoms, because lots of mental health symptoms and drug and alcohol symptoms mimic each other. So we try to have as much information about people as we can get and a good, clear understanding of what we're dealing with. I don't know the exact statistic of how many people test positive for alcohol and drugs that come in, but I feel pretty comfortable in saying that it's probably at least 80%, if not higher. So that's a huge problem.
Do they all come in for help, or do you go to visit their homes sometimes?
We do both. We have a tremendous amount of walk-in traffic now since we have a new facility. We go to people's houses, we go to restaurants, we go to, I used to say phone booths, but we don't have phone booths anymore.
Yeah.
Anybody can call us from anywhere. We meet the police, we meet the FBI, we go to schools, we go to other treatment facilities, we go to emergency rooms, hospitals, wherever somebody needs us to go, that's where we go.
Back on the drug thing, what are the steps that you take to help someone rid themselves of the addiction? How does that process?
The area I work in is kind of like if you've never experienced this type of area before, probably the thing I could relate it to help you understand what we do the best is like as if you have a medical problem and you go to an emergency room.
Right.
We're kind of like a mental health emergency room. We're kind of like the Band-Aid, so to speak. We're going to try to stabilize somebody as quickly as possible, and then we're going to direct them or transfer them to some type of facility or resource to get them help. So we don't necessarily do treatment per se.
You're the emergency room for mental health.
Basically, yes.
Do you refer any of these, I think they're called, not patients necessarily, but consumers?
We call them consumers.
Consumers. Do you refer any of these consumers to faith-based organizations ever?
Yes, we do. I mean, we use any type of resource that we can get.
Is that a tool that you use within the organization, or can it be since you're
It can be
part government or something?
It can, yeah, it can be. Well, the government piece for us is more or less our working relationship with the state government and some other entities for funding, because we're a grant-funded program.
Okay.
We don't charge per se for care. Anybody comes into our facility, the last thing we worry about is their ability to pay us or what type of insurance they have. We will help anybody. But as far as the type of care and things that we can do for people, we're not regulated on that based on whether a person's religious beliefs or something.
Are you limited in perhaps even praying for the person? Is that ever done?
You know, I won't say that it hadn't happened.
You say it does not happen?
No, I would not say that has not ever happened.
Okay.
You know, if somebody did that with a consumer as part of the interventive process to help them, I would have no problem with that whatsoever. Because we look at people from a holistic approach. People are very complicated. We as human beings are very complicated. You know, your mental health is attached to your spiritual health, which is attached to your medical health. We try not to be myopic and just look at one sense of a person. We have to look at the whole person to try to make an intervention with them.
Like you said, that leads me to this video I want to play. It's about a young lady. She suffered from depression since the age 13 with anxiety and depression. And at age 20, she was sexually assaulted by her pastor after dating for 11 months, suffered PTSD, and she's going to share some of her views on this video, then maybe you can comment on it. So let's roll that. Sure.
I'm going to talk today about faith and mental health. If you have talked to many people of faith, or if you've been in the Christian community, my guess is that you've probably heard lines like, oh, you just need to pray about that, or that's a spiritual issue, or just take that to God. I've come to the realization that If you're struggling with anxiety or depression, or PTSD or bipolar, or fill in the blank with whatever mental health trouble you are having, it is not because your faith is not strong enough. I feel like I could repeat that all day. It is really not because you are not strong enough, or your faith is not strong enough, or anything. It's not because you're not praying hard enough. It's not because you haven't read enough scripture. It's because there are things that are chemically wrong with our bodies. There are things that go wrong in our minds, and that's okay. You are not to blame for that. You are not wrong for that. There are a lot of solutions that you can try, and some of it is investing in your spirituality. Some of it is talking to a doctor. Some of it is talking to a counselor. Some of it is exercise and, going outside like so many people say to do. It's so many things. There is no one answer, and you are not failing as a Christian because you are looking for other answers that aren't just God.
So I guess I'm saying there. Here we have the component of prayer with our counseling center in our facility here, as well as other tools, and she's saying that should be the case. But I think there's a mindset that I was not aware of, perhaps in the religious community, that if you just pray about it, prayer is very important, but there may be other, they had doctors in the New Testament,
Right.
There are other tools that we should use. Have you encountered any of that in your dealings?
Absolutely. I think the young lady in the video is spot on.
Okay.
Obviously, God is a very powerful entity, and he can do anything he wants to. But a mental illness in the world that we live in is just like a physical illness. It has to be treated appropriately. If people can pray and that makes them feel better and that works, awesome. If it doesn't, that doesn't mean it was ineffective or wrong. It's just like taking a certain type of medication. A certain type of medication may work for me where it may not work for you. And once again, I think what we have to keep in mind is the holistic approach to every individual. We are very complicated entities. I encourage anybody to use any tool they can to be healthy. And, I don't know how many times I've told people that have come into our office that I've sat down and spoken with that are struggling or need an intervention. What I need them to do, and what people forget to do, is I need them to take care of themselves. That's what's going to keep them out of our facility. And be whatever that may. And when I say that, I mean healthy things. Mm-hmm. Whether it be your spiritual life, the people you associate with in your spiritual life, your church, psychiatrists, nurse practitioner, counselors, therapists. Some people like to go to a holistic medicine approach. I don't think there is a wrong answer there. Not all professionals may agree with that, but typically the people we see are very sick individuals. They're on their last step, so to speak, or the end of the rope oftentimes. And we will get very creative and do whatever we need to do to help these people.
Tell me about the experiences you've had with those who are suicidal, especially young people.
Yeah. It's interesting. Several years ago, I had the pleasure of going to see the Surgeon General. He came here to Nashville and gave a speech at some hotel, I don't remember where it was. And I believe his last name was Fletcher. And, usually the surgeon, whoever the U.S. Surgeon General is, has kind of a theme that he bases his time on, so to speak. And General Fletcher's theme was mental health. In the day I got to see him speak, it was pretty fascinating. I don't know where suicide ranked on the list of cause of death at that point in time, but he said within the next 20 years it would be in the top 10. I think currently, if I'm not incorrect, I think it is number 10. I think it has the potential to go even higher.
What is the driving force behind that people are suicidal? A multitude
yes, a multitude of things. There's typically a couple of things in specific we look for. Obviously, there's lots of red flags. If a person is hopeless and disconnected, those are probably two of the largest red flags that we look for. I mean, we all have bad days. We all have problems. Some of us suffer from very traumatic experiences. But it seems like the people that lose all hope in life and become very disconnected, which seems to be a very, very strong indicator that this person's in real trouble and we need to get them help, like quickly.
Have you had some success stories you can relate?
Lots of success stories. That's hard for me to share because since I'm working in kind of an emergency scenario, we see people very briefly, and then we move on to the next intervention. We don't typically follow them. We get letters from people. Sometimes people will come back by and ask to speak to whoever helped them, to thank us, and to send kind words or words of encouragement for us about what we do, so to speak. But that's kind of a rare occurrence, but it does happen.
There are a couple of them on your website that one says, "I'm so thankful for your staff for being so respectful and caring in my darkest moment. They gave me hope. I will forever be grateful to the Mental Health Cooperative. The Mental Health Cooperative saved my life. We couldn't find services that worked for our teenage daughter until we came here. The team helped us create a plan that worked." Back to the suicide part again. When I was on the tour with you, you mentioned about sometimes on the news you see a jumper on a bridge and the police are there and the fire department, and also in the background there is the people in plain clothes, and that could be you, right?
Right.
What are you doing when that happens?
Assessing the situation, working in conjunction with the first responders on scene to help determine what needs to be done. We're also assessing not only the situation but the person as best as we can to go ahead and start that process of helping determine what needs to be done once we secure that person in a safe environment, so to speak, or safe situation, so to speak. So yeah, they're there on scene.
Right. This past weekend we had terrible mass shootings. Do you have any thoughts or comments about that as related to mental health, or do we tend to blame it, put the blame on that exclusively, or just what are your thoughts about that?
After working in this environment that I've worked in for 22 years, I tend to probably not be as emotional about a lot of things that a lot of other people may be emotional about. But I will say this, that's probably the one scenario that I think affects me the most. And I think the reason being is because, like, when individuals come into our facility or we go see somebody, we usually have a good idea prior to the intervention as to what's going on. And I don't know about, I will only speak for myself. I would assume that a lot of the people I work with do the same thing. Probably half the time I already have a plan mapped out in my own mind what I'm going to do when I get in front of them. I don't have a good answer for these scenarios, and I think that's what kind of scares me a little bit about that. I think about them often. I try to wrap my head around them, so to speak, and I find that I don't come up with a lot of good answers. Mm-hmm. And I think that's one of the big struggles our government, our resources, the people in our country are struggling with right now is why is this going on and how can we stop it? I think people want to tend to blame certain aspects or certain things, and I'm not convinced so far that they're looking in the right direction, so to speak. I will say this, you know, as the first tape that you showed, typically people with serious persistent mental illness are not violent people. If anything, they're probably the opposite. I think what people forget is that people with serious mental health issues like schizophrenia are a degenerative disease. Their cognitive ability and their overall mental health will deteriorate over time, even with treatment. So if anything, they become more of a non-threat, I would say. My boss and I were talking recently about these particular scenarios because, like I said, it kind of, I feel this one deep in my heart. And we were talking about it, and he was sharing with me that what researchers have found, and I don't know the exact specifics of it, but in a nutshell, what researchers have found that within the so-called population of the mentally ill, or particularly like people with schizophrenia or thought disorders, which could lead to other things besides schizophrenia, there is kind of like a small subset of people that do have the ability to be violent and or the resources to obtain the tools or the plan in order to carry something like that out. I don't know how recent this research is, so to speak, but it does exist. But this is a very difficult problem. It is a very serious problem. And like I said, the thing that really concerns me is even after working in this particular, you know, scene, so to speak, for 22 years, I still have a lot of questions that need to be answered.
Shifting gears a little bit, when I'm out on the street, Walgreens, Walmart, people approach me for money. Homeless people, are they typically suffering from a mental illness or just down on their luck, or is there a general thread there?
I think it's both. I think you know, if I had to take an educated guess, I would say a lot of those people probably do suffer from some type of mental illness. I know of a lot of those people. I come in contact with them, or our team comes in contact with them often. I see them around town. I usually know them. I know a lot of them by name because I've had experience in dealing with them. You know, the system, be what it may, is not perfect. At times it's difficult to navigate. And you also have to take into account that everyone has civil rights, and, you know, they can refuse treatment for whatever reason. That's one of the difficult pieces that we deal with on a day-to-day basis.
I want to take time for some questions, maybe more time than usual, hoping that you'll have some comments or questions for Stan. Jeff is ready with a microphone.
You're welcome. That's really cool. Did they pay you to be here? That's awesome. Wow. Okay.
Stan,
Hang on.
I have a question I want to ask you.
Is that Jerry Sherrill back there?
That's it.
Awesome.
Those that have lived around here in Madison, Old Hickory, remember the Madison Sanitarium, which had a mental health unit. And part of their therapy was shock treatments. And I wondered if that is still the case today, that they still use that type of treatment.
Yes, sir, they do. They refer to it as ECT, electroconvulsive therapy, I believe.
It doesn't sound good.
It's not. No, I guess it is, but it isn't. Actually, it's probably not what you think, or not like that old picture that popped up on the, or if you've watched any of these old movies about stuff like that. I don't think it's quite like that. Maybe it was back in the day, I'm not sure, but that is a type of treatment. Usually what we see is, typically when I've come in contact with people that have been treated by that, it's kind of like they're not responding to medications typically associated with depression, so to speak. So actually what they're basically doing is, you know how you can reboot your computer at home? They're basically rebooting your brain, so to speak, because it's obviously not working right. But yes, they do.
Someone had a comment about children and your children's services.
Children? You know, I have to tell on myself a little bit. Typically when I look at working with the mental health population, the first category of people that pop into my mind are adults, because theoretically speaking, that's what I've done the most of. Our team actually won the state contract for Davidson County to also pick up the children's crisis team. We've been doing that for a few years now. So basically as of now, we see people of all ages. I think the youngest person we've done a crisis call on was 4 years old, I think, which ought to concern you a little bit. Children are tough. That is a really tough call to go on. Probably one of the toughest calls I've ever done personally was a kid. Because not only are you assessing them and trying to do an intervention with them, you got to think there are people responsible for this child. So if you're doing a crisis call on a child, you're pretty much doing a crisis call for the whole family. And people take their children very serious, or the care of their children very serious.
Is it depression? What is it that's occurring?
Oh, it can be anything. Lots of behavioral problems in a result of being exposed to a traumatic environment, abuse, both physically and mentally. You know, we have this lovely thing now that a lot of children have to deal with called ADHD. Right. We see lots of that. Teenagers are typically preteen teenagers, a lot of suicidal ideations. We get lots of calls from schools about kids that are overwhelmed in bad situations, peer pressure, you name it. I mean, if you can come up with a reason, I'm sure we've seen it, where kids are starting to have thoughts about taking their own life. And
why is that more prevalent now than, at least it's talked about more, if
well,
nothing else?
I think that's probably one thing. You know, we live in an age now where information is instantaneous. I think we just hear about a lot more things now.
Is bullying a part of this?
Sure.
Have
Absolutely.
you had some experiences?
Oh, yeah, absolutely. We've seen lots of children at schools that are being bullied, don't want to go to school, refuse to go to school, say if they have to go to school, they're going to take their life. So we have to intervene in those situations and try to help resolve that situation and get them pointed in the right direction.
Anybody else, Jeff?
On this active shooter situation, getting back to that, some, if not all, of these people, after the fact, has always said that they're being watched by somebody, or they've been reported by somebody, and they didn't go far enough to find out what was going on, and they've gone over the edge. So what can be done to maybe watch them a little closer if somebody is reported?
Right.
I mean, these two guys that just did this over the weekend, both were reported according to the news media. Now, that's not always a good source, but they've all been reported as to, you know, they might do something.
Right.
And I just wondered why they're not being watched any closer than what they are.
Well, in all honesty, I can only speculate on a lot of that because, you know, a lot of these types of things, I don't have enough information to know exactly what went down or what was going on with this person before something like that happened. You hit on a key word there in your question, and that word is might. I might do something tomorrow, and I might not. And it's hard to take a person's civil rights away from them based on the word might. And that's a very fine line. I know of lots of people right now that are being watched, but if they're not doing anything, you can't do anything to them. We can debate that all day long if you want to. I don't make the rules, so to speak, but I sure do have to play by them, That's like when we involuntarily commit a person against their will to a psychiatric hospital. There's kind of a line in the sand, so to speak, and sometimes that line gets a little blurry or gets a little gray. But I have to wait till they cross that line before I can do that. And I don't know if that answers your question, but...
It pretty much does answer that question, but it also leaves it open that every time something happens, everybody hollers, take the guns away. Guns can't kill people.
Yeah.
It takes somebody behind the gun to kill somebody.
Well, I think...
And that's an important thing as far as what we have in our Constitution. And I know the Constitution works both ways, but
sure.
Something's got to be done because these people, it seems to be getting worse. And
I agree.
The answer is not to take the guns away. Because then when you do that, you're going to get into a civil war. I'm afraid. Yeah. And it's just going to be rough all the way around. And to step on somebody's rights because they might kill somebody, that might be a better thing than causing a civil war.
Yeah, there's, once again, I think you get into a lot of things that when scenarios like this happen, people, I know if you watch TV and all those, all the media and stuff like that, everybody wants to blame something. Or lots of times, I think, and this is my opinion, it doesn't mean anything. Lots of times people want to blame things that I don't think are really what needs to be blamed. There's a huge problem here, and we need to figure out the right way to deal with it. When you start blaming inanimate objects or whatever, that's not going to fix your answer. That's not going to fix your problem. We could carry that debate on all day long. The problem is more resources. You ask, how can we do a better job of watching these people? Well, there's probably 330 million people in the United States right now. It would take a large group of people to watch all these people, and we don't have that. Now I'm going to say that's a little speculation on my part. I know with the resources that we have here in Nashville, I think the people that we work with do a great job of trying to do that. but I know it's not enough.
I used to teach, and so when I came across someone that I thought had a hit list or a rape list like they talked that this young guy had,
Yes.
you know, my immediate response was to get that off my back and take it to the next person up, the guidance counselor, and let them handle it because that's what they were supposed to do. But what do you mean when you say they're watching them? Because I don't understand how this person was able to purchase a weapon if he had been known to have a hit list or a rape list like that.
They are aware of who that person is. That doesn't mean they're specifically sitting right outside their door, you know, hawking them 24 hours a day. They are aware of that person, so therefore if any complaints come through, they are keyed on that very quickly. Typically, your local law enforcement are the people that get involved with them first. Then I would imagine that probably flags FBI, Secret Service, whoever. Usually those types of people, we're dealing with like FBI and Secret Service on, because that's turning more into a federal issue than it is a local. But they're all involved.
Can you sense that there's a frustration with the mass shootings going on in the country? We all want some type of
everybody wants that
magic
answer.
button or
Sure,
answer.
absolutely. Oh,
Yeah.
man, yeah. We talk about it all the time.
Yeah.
Sure,
What
absolutely.
else?
Yes, my sister, she's like struggling with schizophrenia. Well, you know what I mean.
Yes, I do.
But anyway, so she's in and out of jail, like the lady on the tape was saying, and they'll send her to Centennial, and like you were saying, she can always sign herself out. So my question to you is, I kind of missed the introduction today about your treatment center and what all you all do. If a person do come to your treatment center, how long is y'all's process? You know, or if you decide to keep them,
Right.
how long would you keep them? Then I heard you saying something about a grant system. I'm not really familiar with her insurance or anything like that, but her husband, he's really trying to find her somewhere she can get to where she can get some help.
Typically, if somebody comes through crisis and we put them in one of our treatment programs there on site, typically 72 hours, maybe 5 days. 5 days would be a lengthy stay. You know, go ahead.
Could they come back then? And so they have
Sure.
a reoccurrence?
I've had somebody come through and they're
Almost
you know,
like a revolving door?
Crisis sees them. They're there for 3 or 4 days, 5 days, something like that. 2 or 3 days later, they're back.
I see.
Sure, absolutely. Our job is not to judge who and how often. Our job is to intervene. There's people in Nashville we've seen hundreds of times. That's okay. That's what we're there for. Your case's scenario, so to speak, as far as her, what did you say, as her husband was trying to get her some resources or whatever?
No, her husband's trying to find somewhere instead of in and out of jail, because, you know, she'll walk down the street, in the middle of the street, and then she'll end up in jail. Sometimes to me, I feel like she's safer there,
in jail.
but it's a process.
Here's a very frustrating thing that people will encounter when they're dealing with seriously, persistently mentally ill people. A portion of that population, not everyone. One of the key things in dealing with people is their ability to have insight into their own situation. You know, I see people sometimes, or we see people sometimes that are really, really sick and really, really delusional and have all these wild ideas and thought processes and stuff like that. They think there's absolutely nothing wrong with them whatsoever. Those are the hardest people to treat. Those are the people that get caught up in, oftentimes, in what you're referring to, what we would call a revolving door process. You know, they go in a hospital, they get stabilized, they clear up. As soon as they walk out of the hospital, they stop taking their medicine or they're following their treatment program. 3 or 4 days later, a week later, a month later, you know, they're right back. That's very common, actually.
I'm a school teacher also, but I teach up in Robertson County. Mm-hmm. Is there facilities like yours in surrounding, like the donut counties, Or do y'all reach out and go into the counties surrounding Davidson County?
Okay. Every county has its own crisis team. Now, as to what type of resource they have access to, some may not. And I don't specifically know about your county, I'm sorry. Now, that's not to say that if somebody in your county shows up at our door, we're not going to help them. Sure we are. Yeah, sure. That happens all the time.
Did we not cover something that you want to elaborate on before we close out?
You know, it's difficult at best oftentimes. I just encourage people to take care of themselves. I encourage you to be supportive and with anybody that you know that suffers from mental illness, whether it be a family member or a friend. And I also want you to understand that it's not necessarily your job to fix them, because I can pretty much assure you, you can't. That's what we're for, and that's what they pay us for. And a lot of times, not even I or my team can, but we're sure as the world going to try. Anyway, we're here for anyone and everyone, and our door is always open. We're not perfect. I would say if you come to us, come in with low expectations and hope for high outcomes, because that's what I do every day, because we take it a day at a time.
And you got to go back to work right after this.
Yes, sir, I do. I'm still on call right now.
Appreciate you taking this break to be with us tonight. Thank you so much.
Appreciate you having me. Sure. Thank you, sir. Thank you.
Well, let me ask you a question. Where are you on your journey of faith? Have you begun the walk? Are you walking and stumbling perhaps like we are? 1 John 1:7 says, "But if we walk in the light as he is in the light, we have fellowship one with another, and the blood of Jesus cleanses us, purifies us from all sin." We'd like to hear from you. Our contact information is on www.storiesofamazinggrace.com website. We'll see you next time on Stories of Amazing Grace.